Okay, this is the second part of the chapter 35 PowerPoint e-lecture. And in the last part, I finished explaining this slide. Now let's go to the next slide. And this is mechanical system, and mechanical system of heart is systole and diastole and stroke volume. I explained this in my heart failure slides very well, so we'll move on to the next slide. This also I covered in the heart failure PowerPoint. Cardiac index, it's the cardiac output divided by body surface area, and the the why we need to know the cardiac index. Cardiac index actually adjusts the cardiac output to the body size. Um, I don't think you need to know too much about the cardiac index. I would be more interested for you to know everything about cardiac output, the definition, and how it plays roles in maintaining homeostasis in our body. So let's go to the next slide. Preload, contractility, and afterload. Um, if you have to memorize the preload, contractility, and afterload, uh, definition or explanation, I would say do it from your book. So whatever is the definition of preload, contractility, and afterload from the book. And for the purpose of understanding preload, contractility, and afterload, I did that very well in heart failure PowerPoint. Let's go to next slide. Audience response question, and this is a question, it's a practice question. And this is patient is receiving a drug that decreases afterload. Um, to evaluate the patient's response to this drug, what is most important for the nurse to assess? So the correct answer is blood pressure. Why? Because the afterload is affected by three factors: size of the ventricle, wall tension, and arterial blood pressure. So that's why the correct answer is blood pressure. Um, let's continue to the next slide. Now we will talk a little bit about the vascular system, and you might have heard this term so many times throughout your nursing program, from first semester till now. Um, the vascular system has few components, which is blood vessels, and blood vessels again is subdivided into arteries, arterioles, veins, venules, capillaries. What is the purpose of arteries? Arteries, they carry oxygenated blood away from the heart. So arteries begins with the letter A, and away also begins with the letter A. So just remember, arteries carries oxygenated blood away from the heart, except for the pulmonary artery. Okay, so that's the exception. Veins, they carry deoxygenated blood towards the heart, except for the pulmonary veins. Small branches of arteries and veins are arterioles and venules. So small branches of arteries are called as arterioles, and small branches of veins are called as venules. Blood circulation from the heart goes into arteries, arterioles, capillaries, venules, veins, and then it goes back to the heart. So from heart it starts and it goes through all this, um, these blood vessels, which I call as like a whole network of tubes and pipes. And then after traveling through all these tubes and pipes known as arteries, arterioles, capillaries, veins, and wells and veins, then blood goes back to the heart. Now let's go to the next slide. Comparison of artery, vein, and capillary. The arterial system differs from the venous system by the amount and type of tissue that makes up the arterial walls. Um, if you see here, arteries and arterioles, let's talk about arteries and arterioles. The large arteries, they have thick walls and they are composed mainly of elastic tissue. This elastic property of these large arteries, it cushions the impact of the pressure which is created by the ventricular contraction. And this elastic property, besides cushioning or giving a cushion to the impact of the pressure created by the ventricular contraction, also provides a recoil that propels blood forward into the circulation. Large arteries also contain some smooth muscle. Examples of large arteries are the aorta and the pulmonary artery. The innermost lining of the arteries is the endothelium, and the endothelium is helps in maintaining the homeostasis, and it promotes the blood flow, and also under normal conditions uh, it also inhibits blood coagulation. So when the endothelial surface is disrupted, example, when endothelials um, uh, is there is a kind of a rupture of this endothelial layer due to some kind of plaque, the the coagulation process is initiated and it results in formation of more clots. So the innermost lining of the arteries is the endothelium, and the endothelium um, is plays a very great role in maintaining the homeostasis and also promoting blood flow, and it also helps in under normal conditions to inhibit blood coagulation, like uh, doesn't let blood clot easily. When the endothelial surface is disrupted due to some kind of plaque, or example, uh, plaque which has ruptured due to atherosclerosis, the coagulation cascade is initiated and it results in the formation of more clots. So that's why this inner layer of the arteries, the endothelium, is very important. Capillaries, the thin capillary wall is made of, and the thin capillary wall is now also made of endothelial cells with no elastic or muscle tissue. The exchange of cellular nutrients and other metabolic products, it takes place through these thin walled vessels which are known as capillaries. So capillaries connects the arterioles and the venules. So there is a great importance of this endothelial layer of cells. Then we have small venules and also veins. Now veins are larger diameter, and but they are also thin walled vessels, and they return the blood to the right atrium. The venous system is a low pressure area, but it is high volume system. So in the venous system, there is low pressure but high volume. The larger veins contain semiannular valves at intervals to maintain the blood flow towards the heart and to prevent the backward flow. Now, the amount of blood in the venous system, that is veins and venules, is affected by a lot of factors, including the arterial flow. How the blood flow inside the arteries is happening will also affect how the blood flow inside the veins are happening. And then compression of veins by skeletal muscles, any alteration in thoracic or abdominal pressure, or any right atrial pressure. So this all will affect the amount of blood in the venous system. The largest veins in our body are the superior vena cava, and which uh, superior vena cava, which returns blood to the heart from the head, neck, and arms, and the inferior vena cava, which returns blood to the heart from the lower part of the body. So um, make sure you know the importance of the endothelium in the comparison of artery, vein, and capillary. What is the role of endothelium in the vascular system? Okay, let's go to the next slide. Uh, how does the regulation of the cardiovascular system happens? We touched a little bit of this in the heart failure slide, but now we will touch it in a little more in detail. Um, we have we The cardiovascular system gets regulated by autonomic nervous system, and it consists of the sympathetic nervous system and the parasympathetic nervous system. Now, stimulation of the sympathetic nervous system, it increases the heart rate and it speeds the impulse conduction through the AV node, and it also speeds up the force of atrial and ventricular contractions. And there is something called beta adrenergic receptors, and there is a when there is a stimulation of the sympathetic nervous system, there is also stimulation of beta adrenergic ad, adrenergic receptors in smooth muscles, which results in vasoconstriction, increasing the blood pressure. So when we say flight and fright response in the sympathetic system, it speeds up a lot of things inside our heart too. It speeds up the impulse conduction through the AV node, and it also speeds up the force of atrial and ventricular contractions, and then it also stimulates some receptors which are known as um, beta adrenergic receptors, which results in vasoconstriction, increasing the blood pressure. Now let's look at from the other side. What if there is a stimulation of the parasympathetic system? Now, stimulation of the parasympathetic system, which is done or which is mediated by the vagus nerve, it slows the heart rate by decreasing the impulse from the SA node and thus conduction through the AV node. So the opposite happens when there is a stimulation of the parasympathetic system. So that's how autonomic nervous system regulates the cardiovascular system through sympathetic and parasympathetic system. There is something called baroreceptors. Um, Baroreceptors in the aortic arch and carotid sinus are sensitive to stretch or pressure within the arterial system. So these baroreceptors are very sensitive if there is any pressure or stretch within the arterial system. Stimulation of these receptors, example, if there is a volume overload in the heart, it sends information to the vasomotor center in the brainstem. This results in temporary um, kind of uh, stoppage, like stop of the sympathetic nervous system, and it enhances the parasympathetic influence, thereby causing a slower or decreased heart rate and peripheral vasodilation. So that's how um, the baroreceptors play a role. So there is something called baroreceptors in the aortic arch and carotid sinus, and which is very sensitive to stretch or pressure within the arterial system. And when there is a stimulation of these baroreceptors due to volume overload in the heart, it sends some information to the vasomotor center in the brainstem. And this will result in the temporary stoppage of the sympathetic nervous system, and the parasympathetic nervous system gets stimulated. And as I said earlier, if the parasympathetic influence comes in, it causes a decreased heart rate and peripheral vasodilation, and decreased arterial pressure causes the opposite effect. So that's how baroreceptors they play a role. There is something called chemoreceptors, and these are located in the aortic and carotid bodies as well as in the medulla. Uh, chemoreceptors, they are capable of causing change not only in blood pressure, but they also can cause change in respiratory rate. And if there is an increased arterial carbon dioxide pressures, which can be easily called as hypercapnia. And now the chemoreceptors, which are located in the aortic and carotid bodies and the medulla, they can cause change in respiratory rate and BP in response to increased arterial carbon dioxide pressure. So hypercapnia can cause change in respiratory rate and BP, and with help of chemoreceptors. And the blood pressure, in this case, the blood pressure increases when this happens. Okay, let's go to the next slide. Blood pressure, and I think this is a very familiar term with you all. Systolic blood pressure should be systolic blood pressure should be less than 120 millimeter mercury, and diastolic should be less than 80 millimeter mercury. And blood pressure is equals to cardiac output times uh, systemic vascular resistance. Um, the Now in the class I said these days, I mean, systolic blood pressure can be also 90, is considered 90 to 120 as normal. But that is more practical and that's for the floor. But for the purpose of exam, you study what your books tells you. Okay, what is the parameters for systolic blood pressure? Systolic blood pressure should be less than 120 millimeter mercury, and diastolic blood pressure should be less than 80 millimeter mercury. The arterial blood pressure is a measure of the pressure which is exerted by blood against the walls of the arterial system. And think of this. Um, let's give you a little bit of an example. If you go in your bathroom or your kitchen and you open the water tap, okay, and if the force of water from your water tap is very high, then the water comes out so fast that you know what you're not able to fill. If you want a glass of water from that tap, you cannot fill a glass of water from that tap. You will adjust the uh, the tap so the water pressure is kind of normal and you can fill your glass of water. Now if the water pressure which is coming from the water tap is not is kind of very low, still you will not be able to fill your glass of water adequately. This is how if you now this is how it this our blood pressure should be within the pipes or within the most important um, tubes in our body, which are arteries. So think of the blood flowing within those arteries is like a flow of water, which needs to have an adequate pressure. If the flow of water within those flow of water uh, no, no, if flow of blood within the arteries is too much, it will exert too much pressure on the arteries. So we don't want that. The flow of blood within the arteries should be normal. The and the This pressure in the is in this pressure can be analyzed in two ways. Once when the heart contracts and once when the heart relaxes. So the systolic blood pressure is the peak pressure exerted against the arteries when the heart contracts. The diastolic blood pressure is the um, residual pressure in the arterial system during ventricular relaxation or filling. BP is usually expressed as a ratio of systolic to diastolic, as we all know. The two main factors which can influence blood pressure are cardiac output and systemic vascular resistance. What is systemic vascular resistance? It is the force opposing the movement of blood. So this force is created primarily in small arteries and arterioles. Normal blood pressure is systolic is less than 120 millimeter mercury and diastolic is greater than 80 millimeter mercury. So make sure um, you know what happens during systolic blood pressure and diastolic blood pressure, and the definition of systemic vascular resistance, which is the force opposing the movement of blood, and this force is created mainly in small arteries and arterioles. Let's go to the next slide. Blood pressure can be measured by invasive and non-invasive techniques. Um, Now, I have uh, done a lot of charting in um, Kaiser in the KP Health Connect system and also in the other electronic medical record system, and it always tells you when you have it the drop down menu on the blood pressure, it always asks you whether it is invasive or non-invasive. So today we learn what do we mean by invasive and non-invasive blood pressure. Now the invasive technique consists of catheter insertion into an artery. The catheter is attached to a transducer and the pressure is measured directly. Non-invasive is the indirect measurement of BP, which can be done with a sphygmomanometer and a stethoscope. And you all have seen that. The sphygmomanometer consists of an inflatable cuff and a pressure gauge. And the BP is measured by auscultating for sounds of turbulent blood flow through a compressed artery, which is also known as Korotkoff sounds. The brachial artery is the recommended side, and that's how we take the BP. After placing the appropriate size cuff on the upper arm, we inflate the cuff to a pressure of approximately around 20 to 30 millimeters of mercury, uh, and that above the systolic blood pressure. This causes blood flow in the artery to cease, and if the systolic blood pressure is not known, we estimate the pressure by palpating the brachial pulse and inflating the cuff until the pulse stops. The pressure noted at this time is the estimated systolic blood pressure. Inflate the blood pressure cuff 20 to 30 millimeter mercury above this number, where the pulse stopped. Um, As the pressure in the cuff is lowered, the artery is auscultated for cough sounds. And there are 5 phases of cough sounds. I mean, like in the beginning stage, you heard the tapping sound. Now we're not going to go deep into the cough sounds. Blood pressure is recorded as systolic, diastolic, and proper BP technique is very important. And you all know the correct cuff size, positioning of the arm at the heart level is important for accurate readings. Another non-invasive way to measure BP directly is an automated device that uses some oscillometric measurements to assess the BP. Um, now um, we will not go deep into this oscillometric measurement, but systolic blood pressure can be also assessed using a Doppler, which is Doppler ultrasonic flow meter. It is a handheld transducer which is just positioned over the artery, and it is identified by audible pulsatile sounds. It's very clear. The cuff is applied above the artery, inflated until the sounds disappear, and then another 20 to 30 mercury beyond that point. The cuff is then slowly deflated until sounds return. This point is the systolic blood pressure. So you will see sometimes nurses using this Doppler to measure the blood pressure. If you see this on the floor, then ask them, if you can use it and try it. So the oscillometric measurement device which we were talking about in the last slide was this is the picture, and we buy this from CVS Rite Aid Pharmacy, and I think it's almost in all the houses. I have this in my house too. Now let's go to the next slide. Um, there is a picture of Doppler ultrasonic flow meter, and the handheld transducer, as you can see, is being positioned over the artery, and it is identified by the audible pulsatile sounds, and then the cuff is applied above the artery, inflated until the sounds disappear, and then another 20 to 30 millimeters of mercury beyond that point. The cuff is then slowly deflated until the sounds return. This point is the systolic blood pressure. So when they have some nurses, when they have difficulty finding, you know, the pulse, so they use this Doppler, and I think it's almost on all the floors. Most of the floors have this kind of Doppler blood pressure machine. So, and it's just a handheld transducer which is positioned over the artery, and the nurse hears the audible pulsatile sounds, and then cuff is applied above the artery at this point, inflated until the sounds disappear, and then another inflated, and then when the sounds disappear, they go a little more beyond the point, like little more 20 to 30 millimeter beyond that point, and then after some time the cuff is slowly deflated until the sounds return back, and this point is the systolic blood pressure. um, you can go to YouTube, and there are various videos on this Doppler blood pressure Doppler. There is something called pulse pressure and mean arterial pressure. Now, what is a pulse pressure? Pulse pressure is this difference between the systolic blood pressure and diastolic blood pressure. It is normally about 1/3 of the systolic blood pressure. So if the blood pressure is 120 over 180, then the pulse pressure is 40. So because 120 minus 80 is 40. So that's what it says. The blood pressure is the difference between the systolic blood pressure and diastolic pressure, and it is normally about 1/3 of the systolic. So if the BP is 120 over 80, the pulse pressure is 40. And if the pulse pressure is increased, and then it may occur during exercise or in individuals who have um, atherosclerosis of the larger arteries as a result of increased systolic blood pressure. Decreased blood pressure may be found in heart failure or low volume or hypovolemia. So that's why the pulse pressure has some importance. It is Pulse pressure is the difference between the systolic and diastolic. If somebody has systolic of 120, diastolic of 80, the pulse pressure is 40. And an increased pulse pressure may occur during exercise or individuals with atherosclerosis of the larger arteries as the result of increased systolic. Decreased pulse pressure can be found in heart failure or hypovolemia. Mean arterial pressure, and it refers to the average pressure within the arterial system that is felt by organs in the body. It is not the average of the diastolic, it is not the average, it is not the average of the diastolic and systolic pressure because the length of diastole exceeds that of systole at normal heart rates. So how MAP is calculated? MAP, the formula of MAP or mean arterial pressure is equals to systolic blood pressure plus 2 dBp divided by 3. So if a person with a BP of 120 or by 60 millimeter mercury has an estimated MAP of 80 millimeter mercury, and the MAP formula should also be in your book. So refer your book for the MAP formula. It's no big deal to calculate this formula. It's just systolic blood pressure plus 2 diastolic blood pressure divided by 3, and you will get the mean arterial pressure. As I said in class, it should be greater than 60 millimeters of mercury to adequately perfuse and sustain the vital organs of an average person under most conditions. In ICU, they are kind of happy with 55 to 60, but they do want 60. A MAP greater than 60 millimeter mercury is needed to adequately perfuse and sustain the vital organs of an average person under most conditions. And when the mean arterial pressure falls below this number for a period of time, vital organs are not getting perfused and will start becoming ischemic soon. Now, let's look at the gerontological considerations like for old people. The risk for cardiovascular disease increases with age, and CVD is the leading cause of death in adults greater than 85 years of age. It is the most common cause of hospitalization and the second leading cause of death in adults younger than age 85. So CVD is the most common diagnosis in the hospitals, and the most common cardiovascular problem is CAD, which is secondary to atherosclerosis, coronary artery disease secondary to atherosclerosis. It is difficult to separate normal aging changes from the pathophysiologic changes of atherosclerosis because many of the physiological changes in the cardiovascular system of older adults are also result of the combined effects of the aging process, the other environmental factors, and also their lifetime, their also behaviors rather than just age alone. So CVD is the leading cause of death in adults greater than 85 years of age. You see a lot of people with this kind of diagnosis on the hospital floors. And due to age, sometimes the uh, diagnosis uh, becomes kind of difficult, or it's also um, sometimes the symptoms also they show late. Okay, now what age related changes can happen in the cardiovascular system? With increased age, the amount of collagen in the heart increases and the elastin decreases. So these changes affect the, so why do we need to care if there is high collagen and decreased elastin? Because this will affect the myocardium's or the heart tissue's ability to stretch and contract. One of the major changes in the cardiovascular system is the response to physical or emotional stress. Now, there will be a decreased response to stress due to aging. In times of increased stress, there is a decrease in cardiac output and stroke volume due to reduced contractility and heart rate response. The resting supine heart rate um, is not significantly affected by aging. When the patient changes position, example, the patient sits upright, the sympathetic nerve pathway may be impacted by fibrous tissue and fatty deposits, resulting in a blunted heart rate response. So, decreased response to stress happens with aging because the sympathetic nerve pathway also get impacted, and the response in heart rate um, can be not what we usually expect in a normal young adult. Cardiac valves, they become thick and stiff because there's a lot of lipid accumulation and there is degeneration of collagen. Um, the most commonly affected are the aortic and mitral valves. Now, these changes result in either regurgitation of blood when the valve should be closed or narrowing of that orifice of the valve. So, when there is narrowing of that small gateway of the valve, which lets the blood flow forward, which is also known as stenosis, that also happens with age. And if there is a turbulent blood flow across the affected valve, then it results in a murmur. So murmur is the turbulent blood flow across the affected heart valve. The number of pacemaker cells in the SA node decreases with age. By age 75, it has been researched that by age 75, a person may have only 10% of the normal number of SA node cells or pacemaker cells. Um, so that how pacemaker cells also decreases, and there is decreased number and function of beta adrenergic receptors. And as I was saying earlier, the autonomic nervous system control of the cardiovascular system changes with aging. The numbers and functions of beta adrenergic receptors in the heart decreases with age. So the older adult not only has a decreased response to physical and emotional stress, but he's also getting less sensitive to these beta adrenergic agonist drugs. The lower um, and there are some drugs which you will know. I have posted the AHA cardiac drugs, and you will see uh, what drugs are related to the beta adrenergic drugs. What cardiac drugs are related to the beta adrenergic drugs. Um, there are some more changes due to aging. Let's go to the next slide. Blood vessels thicken, and there is less elasticity. There is increase in systolic blood pressure and decrease or no change in diastolic blood pressure. The the there are incompetent venous valves, and there is orthostatic hypotension or postprandial hypertension. So let me explain it to you. What is orthostatic hypertension? You all know, you all have done orthostatic hypertension, but it says that orthostatic hypertension is estimated to be present in more, it is estimated to be present in more than 30% of patients over age 70 with systolic hypertension and may be related to medications or to decreased baroreceptor functions in body. So with age, orthostatic hypertension is also very common. Um, Postprandial hypotension, which is decreased in blood pressure of at least 20 millimeters of mercury that occurs within 75 minutes after eating. There is a decrease in blood pressure of at least 20 millimeter of mercury that occurs within 75 minutes after eating, and this is known as postprandial hypotension after eating low BP. And it may also occur in about a third of otherwise healthy older adults. So this uh, this is another change which happens due to aging. But nevertheless, despite the changes associated with aging, the heart is still able to function adequately under most circumstances. Now, assessment of cardiovascular system, subjective data. We need to have ask the patient. It's very important. Ask the patient what problem has brought him into the hospital or to the healthcare provider, and then what other past history has affected his present condition, his history of chest pain, shortness of breath, fatigue, any alcohol, tobacco use, anemia, any throat infections, streptococcal throat infections, any congenital heart disease, stroke, palpitations, dizziness with position change, syncope, hypertension, thrombophlebitis, intermittent claudication, and varicosities and edema. So this can be all be causes, and this can all be the past illnesses. You have regarding medications, you need to know the current home meds and also the over-the-counter meds and any herbal supplements and now, for example, aspirin prolongs the blood clotting time and is found in many drugs which are used to treat cold symptoms. So you need to have the list of patients, all drugs, their doses, time, and whether the patient even understands how to take them. Um, some of the patients are on sleeping pills, pain medications, that can also affect their cardiac system. Um, Surgeries, so if they have any past surgeries or related to hospital, related to cardiovascular or any other system, um, you can also explain them that it can be some outpatient diagnostic workup uh, and ask them whether they had any ECG or chest x-ray done for getting any baseline data. So something like that you need to know. You need to ask your patients. Um, the subjective data, you will ask them health perception. You want to know their health perception. So do you practice any preventive measures to just decrease risk factors for heart disease? Have you noticed an increase in your heart symptoms such as chest pain, shortness of breath? Does your heart problem cause you to be less able to take care of yourself? So is their heart problem making them uh, have difficulty with their ADLs? Um, have used any smoking, any tobacco, and then you can also use to ask them about their nutritional metabolic pattern. So what's the usual diet? Do they take more of salt, fat, liquid? What is your weight? Or have you lost recently a lot of, have you gained recently a lot of weight? And and when you eat, do you have any shortness of breath? So these are very important things. Very important to know what kind of diet they eat. Usually, um, these patients, they are some of the patients like is they don't drink water, and they also are used to eating a lot of salty and uh, fatty food, not necessarily sandwich, but salty and junk kind of food. Um, Elimination pattern, like do you do your, like when you go to bathroom a lot, like for to pee pee, or you're constipated, or do you have any problem with pee pee? Do you ever strain to have a bowel movement, like lot of constipation and they're straining a lot? And then activity exercise, are they able to go outside and even just walk, or when they go or walk or do exercise, do they experience any kind of fatigue or discomfort? Let's go to the next slide. Sleep rest pattern, cognitive perceptual pattern. Do you ever experience dizziness or fainting? That will come in your cognitive perceptual pattern. Do you experience any pain, chest pain or leg pain with activity? Self perception. Self perception is how your perceptions of yourself change since you were diagnosed with any heart disease, and is heart disease affecting your quality of life? Then you have role relationship pattern. um, you know, how is this illness affected any of the roles that you play in your daily life, as your father, as husband or grandfather? How your significant others have been affected by a heart disease? Sexuality or the reproductive pattern. um, Describe your normal coping mechanisms during time of, no, no, not, we're not going to coping first. We're talking about sexuality, reproductive pattern. Now, has your heart disease caused a change in your sexual activity? If yes, then describe. Do you experience any heart related symptoms during your sexual activity? Then describe. Do any of your medications affect your ability to participate in sexual activities? If yes, describe. And with females, you can say, are you currently taking any oral contraceptives, any hormonal therapy, or drug therapy for any breast cancer? So this is very important. Very important. Now, I would like to point out the fact that if there is a question in your admission form about sexuality and reproductive system or pattern, don't judge the patient by their age. So if there is 65-year-old female or 70-year-old female, you think that, oh, it's not necessary to ask them about their sexual activity. This is wrong, because once I had a patient and she was in 70, and I did ask her, and she did tell me that she was sexually active throughout the month, like with her husband. So it's very important that you don't um, use your false judgment or your own bias, and don't ask older population this, don't skip this question with older population, you ask them also. Coping and stress tolerance pattern. So when they are stressed or anxious, how do they cope? Do they have a history of depression? And then values belief pattern. um, Now, do you feel any conflicts between your value or beliefs and the plan of care? Or is there any cultural or religious belief that may influence the management of your heart problem? So, objective data, and this is what is, now, as I said, objective data is something which you can verify. So we can verify this data by physical examination. We will do vital signs. We will inspect the peripheral vascular system through inspection, palpation, and auscultation. We will inspect the skin for color, hair distribution, and the pattern, venous pattern. And we will inspect the skin for any edema. We can do for clubbing of the nail beds, and I think I explained to you how um, each body part can be reflective of some problem with the uh, can be reflective of any problem related to cardiovascular system. Um, Regarding palpation, you can palpate the hands and legs for temperature, moisture, pulses, and look for edema by depressing the skin over the tibia or medial malleolus for 5 seconds. Normally there is no depression after releasing pressure. If pitting edema is present, grade it from 1 plus like mild pitting edema to 4 plus as very deep pitting edema. Cap refill is used to assess the arterial flow to the extremities. Auscultation and arteries, which are narrow or has a bulging wall, may create a turbulent blood flow. This abnormal flow can create a buzzing or humming sound, which is commonly known as bruit. And this can be heard with a stethoscope placed over that blood vessel. So um, that's how we will check the peripheral vascular system. And common sites for palpating the arteries. This is a very good picture. We have we can palpate the pulses in the neck and extremities for information on our arterial blood flow. We will assess the rhythm, example whether this regular rhythm or irregular rhythm or force. It is important to palpate each carotid pulse separately so there is no vagal stimulation and there is no possible dysrhythmia. Compare the characteristic of the arteries on the right and left extremities simultaneously to determine symmetry. When palpating the arteries, rate the force of the pulse when it is felt, and this can be done by using a scale, which is 0 is equals to absent, 1 plus is equals to weak, 2 plus is equals to normal, and 3 plus is equals to increased, full, and bounding. The rigidity of the vessel should also be noted. Okay, the normal pulse will feel like a tap, whereas a vessel wall that is bulging will vibrate. The term for a palpable vibration is known as thrill. I discussed about this in the class, the anatomical landmarks. Make sure you know the 5 auscultatory areas, which is the aortic, pulmonic, tricuspid, mitral, Erb's point, and so it's very important you know these. The physical examination next go. We did this in class, and Miss Janice, she posted on web access a very good checklist of assessment of cardiovascular system. So please go through that. And we did talk about point of maximum impulse, and when the patient is supine, palpate the mitral valve area for the point of maximum impulse, also known as apical pulse. This reflects the pulsation of the apex of the heart. So, and where is PMI? The PMI is fifth intercostal space, and if the PMI is below the fifth intercostal space and left of the mid-clavicular line, the heart may be enlarged. So that's why we need to record the position of PMI in relation to the mid-clavicular line and intercostal space. Okay, so when auscultating the heart apical area, you should simultaneously palpate the radial pulse. The S1 and S2, the lub and dub sounds of the heart, are best heard with the diaphragm of the stethoscope because they are high pitch. So the first heart sound which is associated with closing of tricuspid and mitral valves, has a soft lub sound. The second heart sound S2, which is associated with closure of the aortic and pulmonic valves, has a very sharp dub sound. S1 signals the beginning of the systole and correlates with the QRS complex on the echocardiogram. S2 signals the beginning of diastole and it correlates with the immediate period immediately following the T wave on the electrocardiogram. Normally, no sound is heard between S1 and S2 during the periods of systole and diastole. Now, there are also other heart sounds called S3 and S4 which are abnormal. Now, let's go to the cardiac biomarkers. So I will stop it here and I will record the next part in the next recording. So from the third part of chapter 35 PowerPoint, we'll start with cardiac biomarkers. Okay, so I'm stopping here.